dialysis patient. However, we try, there will be some patient who has immature or failing fistula, and how to manage that. To answer this, we have Dr. Shahbaj Ahmad from Himalayan Institute of Medical Sciences. We have already introduced you, sir. You can directly start.
Yeah. Good afternoon, everyone. It was to the credit of the panelists and the moderator that the people still are awake so far. And in the morning, while I was coming from the hotel, I was informed by the driver that in Pune, people love siesta. So people are still awake. That's to the credit of the panelist and the moderator. Thank you, organizing committee people. Especially Lobo, sir, and people for inviting me to this meeting. I'm really grateful to you people. Now coming to the topic. Well, AVF is the best arteriovenous access because it requires the minimum maintenance. But, and there's a big but, once it matures, because the rate of failure, it can be as high as 50% or at the minimum 25% in various series, especially with regards to radiocephalic fistula, the best one of them. And in our scenario, what happens, the patients are mostly crash landers. That is, until the patient doesn't have shortness of breath or they can't eat anymore, they won't present to the nephrologist. And even if they present to the nephrologist prior to that, they will say, sir, jab jarat hogi tab dekha jayega. This is the usual answer the patient gives to us. So we don't have any time to construct the fistula in those patients for the expectation of maturation. So these people are to be started on dialysis through a catheter, which has got remote complications, something like occlusion and stenosis. And daily to day complications are fever, which present as chills. During the dialysis, patient complains of chills. Then the technician is hammering, so what to do now? And then you pluck your hair. Oof, if the fistula is matured or yet not matured. This is the common scenario. I would say nobody would be exception to this one in this hall. So that brings to the question, what is the maturation? Well, this is a common problem, but yet there is no unanimous definition of maturity of the fistula. So there are several definitions. They will mean more or less the same, but they are not actually the same. I'll just enumerate a few of them. Functional mature fistula is defined as if an AVF can accommodate the designed amount of flow volume needed for hemodialysis completion within a reasonable duration of time. The other one is physiological maturity. This is the readiness of the AVF for use based on physical examination and or sonographic findings, which include depth, diameter, and flow volume. Another one is functional patency, which is an AVF capable of delivering a flow rate of 350 to 400 mils per minute without excess recirculation to maintain a treatment time of less than 4 hours. Fistula suitability, this is capability of an access to be accessed with 2 needles to maintain an optimal dialysis flow rate of more than or equal to 300 mils per minute during 8 out of 12 dialysis sessions over 4 weeks period. This was in 2018, published in JASN, where they had used the criteria mature AVF as clinical use of the AVF with 2 needles for 75% of the dialysis sessions over 4 consecutive sessions, or measured KTV being more than 1.4 or URR of more than 70%. Still, this called surgical maturity, which is defined as an AVF used consistently enough for catheter removal. Lastly, in 2020, Kedoki defined functionally mature AVF as the one that can provide dialysis with 2 needles for more than 2/3 of dialysis sessions within 4 consecutive weeks. Well, lot of confusion as to what's really the mature fistula. Everyone of us use this term so frequently, but it has been used differently in different publications and literatures. Well, the bottom line is we should be having a fistula which can be reliably and repeatedly cannulated. Plus, it should be providing adequate amount of flow. So this is the bottom line for all the definitions that I used in the past. But still, all the definition use the term like can be. That is, once you start using the fistula, then only you can come to know whether this fistula is mature or immature. That is, if it was mature, it was a good luck that you started the patient on dialysis. But if it was an immature fistula and you attempted cannulation, the result would be you might be having more problem, hematoma forming over there. There may be thrombosis of fistula also. Okay, so this is only in retrospect you can say that our fistula was not mature. Mature, again, you can say in retrospect only. What about preemptive fistula? Those lucky patients who are still not in ESRD stage, not requiring dialysis, and you construct the fistula. Now you have plenty of time. But the question is, if you can designate this one mature or immature. If you designate it as immature fistula, then only you can intervene. And I would say from my own experience, when we intervene in the immature fistula, you'll have to still give some time so that those segments of the vein which was proximal to the stenosis, they take some time for the maturation. They will have to undergo remodeling. So this is the problem with this all definition, that they exactly do not give any criteria as to what we call the mature fistula. A big confusion. So in 2006, Kedoki gave the rule of 6. Everyone would be aware of that one, which is flow rate of more than 600 mils per minute, when diameter of more than 6 millimeter, when depth being less than 6 centimeter, and length of cannulable segment being more than or equal to 6 centimeter. But the problem with the criteria is all of them are opinion based. They have not been validated in this study. So this is an opinion based criteria. So the another one is University of Albany at Brigham criteria, which says an AVF flow of more than 500 mils per minute and diameter being more than equal to 4 millimeter per meter may also be considered as mature, and they have very high fistula maturation rate without any intervention. Coming to the comparison of UAB criteria and Kedoki criteria, UAB criteria has got high sensitivity in predicting unassisted maturation. So in these cases, early intervention will be much lesser compared to the Kedoki criteria, which has got better specificity. So these will be one, if they met this criteria, then they have, they'll tell you that which fistula is not going to mature, but at the cost of increasing the number of intervention in this patient. So these two are complementary, and none of them are perfect. Now what we discussed was flow rate and the diameter of the vein after maturation. But depth is also a big thing, and which we are aware of, like in brachiobasilic fistula, where if it has not been transposed, cannulation will be quite difficult because you don't get the second point where to put the venous cannula. So this is the matter of being depth. So this was the study in Jason published in 2018, where when the diameter was 6.5 mm and the flow was 900 mils per minute, at the depth of 2 millimeter, the probability of overall maturation was 25%. But when it decreased to 4 mm, increased to 4 mm, then the probability was about 50%. And when it went to up 0.9 mm, that is 9 mm, then the probability was even less than 20%. So, I mean, when we are cannulating the fistula, we have to take not only the diameter and the flow, but also the depth to which we have to do the cannulation. This is a common practice, that if you have to cannulate the basilic vein, it's quite difficult because it's deep. Same happens when a brachiobasilic fistula, which is non-transverse constructed. And also it comes into play when a patient is obese. They are very fat in the arm, and a fistula will be deep. Even if they have a normal size, as per this one, Kedoki criteria or UAB criteria, the cannulation may be difficult. So far we talked about maturation. Well, there is no unanimity for the definition of maturation, so is the case with non-maturation. There is also no unanimity to call the non-maturating fistula. So this is defined as insufficient vessel development 1 month after creation with difficulties in cannulation or impossibility to achieve more than 300 mils per minute of blood flow needed for successful dialysis treatment. The another definition is a fistula that had been created for at least 12 weeks but had not matured enough to allow successful cannulation or use during hemodialysis. Again, a big gap, something like 4 weeks and up to 12 weeks. This is a huge gap. I mean, you can consider a fistula, and between this period and a new fistula can mature. So this is a huge gap, but we have to work it. I mean, there's no alternative to that one. So now let us come to the etiopathogenesis of maturation, or what you call maturation. Actually, maturation requires remodeling of both, that is the vein and the feeding artery or the proximal artery. So in due course of time, the vein will also dilate, and so will the arteries. The main initiating factor is the So the main initiating factor is the increased blood flow, which increases the pressure in the vessels. So this is the main stimuli which leads to downstream events through the mediator of different molecules. So if the shear stress is laminal one, it leads to release of the molecules, which leads to expansile wall remodeling and vasodilatation. At the same time, it reduces the molecules, which will lead to cellular proliferation. So it leads to inhibition of intimal hyperplasia and restoration of normal shear stress and outward AVF remodeling. Contrary to this one, in the cases where the shear stress is oscillatory one, there will be the secretion of the molecules, which will lead to inward wall remodeling and poor vasodilatation. At the same time, there will be fibroblast, vascular smooth muscle cell, myoblast proliferation, which will secrete extracellular matrix, and it will lead to intimal hyperplasia. So, in total, to say about what happens once the fistula has been constructed, before construction, you can see there is hardly any diastolic flow when we take the Doppler flow. But once construction has been on the day one itself, after day one, the flow increase in the artery may be as good as 10 times to the normal, and in the vein, the increase may be up to 70 times. So within 24 hours of construction of the AVF, the flow increase is up to about 50% what you expect in 4 to 6 weeks of time. Okay, so it goes in two ways. On the day one itself, you can see the diastolic flow will increase, and thereafter there is dilatation of both the artery and the vein. However, if there is either discrepancy in any of these two, that is artery or vein, if they do not dilate properly, then it will lead to maturation of the failure. Plus, on top of that, there may be a new intimal hyperplasia, which lead to juxtaanasmotic stenosis. So, are there any early predictors of arteriovenous AVF failure? Well, this was published in JVA 2024, which showed that for radiocephalic fistula, brachial artery resistivity index during the first 24 hours, if it was on the higher side, it will lead to, it's a predictor of poor maturation. But the flow volume immediately after construction may not correlate with that one. But after 24 hours, both the high RI and low flow volume, both of them predicted poor fistula maturation. This was the hemodialysis fistula maturation study, where they had taken the several criteria, and they have done USD parameters at day 1, week 2, and at week 6. And they found that AVF blood flow, diameter, and depth, all of these are correlated with the maturation. So they had provided a nomogram sort of thing. Based upon that, if you feed these values on day 1 or week 2 or week 6, you will get a data regarding the probability of maturation of the fistula or fistula failure. So this was another study published in Medicine in 2022, where on day 5 or 7, higher inflow or outflow ratio, inflow velocity, and AVF luminal pressure gradient were associated with a higher risk of AVF non-maturation. Again, this was in Egyptian Journal of Radiology and Nuclear Medicine, where the study was a prospective study. So they had measured the flow at the anastomos on 7 to 14th day of time. And if the flow was less than 200 mils per minute, then the risk of failure was very high. So coming to the epidemiology, so anyone, if you read the initial Brescia-Semino study that was published in NEJM, anyone will be more than happy to have that rate of failure. That's merely 10 to 11%. That is almost 9 out of 10 would mature, but in subsequent series, the failure rate was about 10 to 25%, and the currently it varies from 20 to 60%. The reason of this very high failure rate is because now the standard practice is considered as, standard vascular access is considered as arteriovenous fistula. So we are taking all sorts of patients having many comorbidities, and which will lead to failure of the fistula. So the risk factors are, this is one I have divided, this is a very artificial one. So I have divided into modifiable and non-modifiable, but it's not completely a watertight differentiation. So those modifiable factors, once the patient comes to it in the ESRD set, they're already non-modifiable by the time they reach to us. Something like cardiac disease. This is the one which I often, in the beginning, when I used to construct the fistula, I would consider fistula for any patient. But then I realized if the patient's systolic BP was less than 120, the possibility that a radiocephalic fistula will mature is very little. Those fistula will get thrombosed soon, very soon. Similarly, if the systolic BP is less than, say, 110 or 100, even brachiocephalic fistula will not mature and they will go into non-maturation. They will mostly get thrombose. Other is the patient having peripheral arterial disease, pulmonary arterial hypertension, diabetes and obesity. These are the poor risk factors. Regarding technical part, this is the one which we can take a clue from Japanese practice. There, the nephrologists are constructing almost 50-50. The nephrologists and urologists, they will be constructing 50% fistula each of them. Okay, so they take the lead, and the region they have very high success rate is they are good, well trained. Here, what happens? The junior most surgical colleague, they will be constructing the fistula when it's already 5 p.m. Everyone is closing the unit, and he's just rushing through the procedure. So those fistula are going to fail. And studies have been there where it has been shown that if a surgeon has constructed more than 25 fistula during their training period, their success rate will be much higher. So it requires sort of commitment, and what sort of commitment your surgeons or the operating, I won't say a surgeon, operating person has towards this fistula. Next comes the size of anastomosis. This is again a modifiable thing. If someone considers radiocephalic fistula and you consider fistula size of very small diameter, something like 3 mm, it's very likely to fail. But this is different compared to the brachiocephalic one. Ligand configuration anastomosis, there was a good study by Shahbaj et al. Published in 2012 in Journal of Vascular Surgery probably, where they showed that if the piggyback technique is adopted, then those patients have lesser chances of juxtaanastomatics. Actually, what we do initially is side-to-side anastomosis, the artery and vein this way. Suppose this is the vein, the next was end to side, that is anterior to the artery, and you bring the side of the vein and then you anastomose. Okay, this is the end to side anastomosis. The subsequent part was that this is the artery down. Okay, you make a cut to arteriotomy over here, anterior to the anterior wall of the artery, and in the posterior wall of the vein, you make posterior venotomy. Okay, and then you sew it. Okay, suture it. So this is piggyback. Plus, added to that one, what is being done is that you dissect out the subcutaneous tissue where the vein goes into it, so that it becomes a straight line. So that is called piggyback straight line technique. So it has been shown that these fistula have lesser maturation problem and they have lesser chances of juxtaanastomtic stenosis. Again, care and use of the arteriovenous fistula. Senior technician, they will be able to cannulate many of fistula which youngsters may not be. Okay, so that is the care of the arteriovenous fistula and the person dealing with. Regarding hemodynamic part, which is non-met, is the size of the artery and veins. If the caliber of the vein and artery are less than both, this is varying, but it is accepted that if the vein size is less than 2 mm and artery size is also less than 2 mm, then those fistula will have higher chances of immaturity. And we know that the brachiocephalic fistula, they have failure rate of something like 10 to 15% compared to the radiocephalic fistula, which can vary from 20 to 60%. So this is the place. Again, depth of the vessels, I discussed about this one in the earlier part. Elderly patient and female gender, they have high chances of fistula failure. Regarding the race and ethnicity, again, there was a question, there was controversy as to why the Japanese have got such a high rate of fistula success compared to the Americans. The reason they said that possibly there is some cytokines which is higher in Japanese compared to the Americans. That's why they have beta patency. Coming to the location, just briefly I'll tell you the part, this is the inflow, and here usually what we apply is the Bulldog clamp over here while constructing the fistula. This is the anastomosis, about 4 cm proximal to the anastomosis. The part of the vein is known as juxtaanastomtic segment. So this is mostly accepted as 4 cm. Somewhere it has defined as 2.5 cm, somewhere 5 cm, but usually it's a 4 cm. The anastomosis and juxtaanastomtic segment, these two are known as functional inflow of the fistula. Okay, this is the most leading cause for the stenosis and maturation failure. The second one is accessory veins. Okay, so it accounts for about 20% of the fistula failure. Purely arterial disease and deep vein, they account for about 5%. This is the rough estimate. I'll just give you one study. This was published in KI by G.R. Beathard, the father of interventional nephrology. So they had said that about 75% stenosis under the venous segment, out of which you can see 15% are purely juxtaanasmotic segment, but the juxtaanasmotic segment stenosis are very commonly associated with other lesions. Regarding the arterial stenosis, about 38% were arterial stenosis, but all the time they were accompanied by juxtaanasmotic segment stenosis. So actually what happens, if you're not careful enough and you're doing reflux angiogram, you can find out. But if you pass your KMP catheter or some catheter up in the artery and you try to take an angiogram, you won't be able to find out any dye coming into the venous side. This is the significance of this finding. So the next part is how and when to assess for the maturation of the AVF. So at 2 weeks, basically it's not for the maturation, rather it's for checking any post-operative complication, thrombosis, pain in the fingers, infection, numbness and swelling and distal ischemia. At 4 to 6 weeks, it's accepted comprehensive assessment for maturation should be done, and this is the time most of the interventionalists will feel like that if the fistula doesn't meet the criteria for maturation, they should intervene now. But it should not be beyond 8 weeks, because by that time the secondary lesions will take over and the fistula may not be salvageable at that time. So how to assess for the maturation? Most of the times in many senior dialysis technician and consultant will tell that it's mostly the physical examination that will let you know to find out whether the fistula has matured or not matured. Okay, even you don't need the Doppler to find out. So the finding is that you do the augmentation test and you will feel that it's not augmenting. Okay, so practical part which I find very useful is you try to feel the fistula. You get a very good thrill at the place of anastomosis, and immediately afterwards thrill goes away. What is that? So this is nothing but mostly you are dealing with juxtaanasmotic stenosis. Exception is if you are having accessory vein. So you again go back proximally and you inch towards the fistula, pressing and feeling the thrill. So where you get a complete occlusion, absence of thrill, that is the point where the accessory vein is there. But I would say in 90% of the time, my most common finding for finding a juxtaanasmotic stenosis is immediately after feeling a thrill, it disappears very quickly. Otherwise, in a normal fistula, you'll get, if it's a radiocephalic fistula, you'll get up to the level, at least this one, you'll get a good thrill. So here you get a good thrill and afterwards immediately it goes away. So this is most likely a juxtaanasmotic stenosis. Regarding ultrasound and color Doppler, this is adjunct to the physical examination and not a substitute to the physical examination. Nothing comes to mind and you straightway send to the radiologist to find out what's there. Okay, so difficult. It helps in assessment of vein diameter, depth, AVF flow can be assessed, presence of any stealing veins, either they are collateral or accessory vein. This definition is somewhat different. When we say it's accessory vein, we mean that those veins are normal, it's not pathological. But when we say it's a collateral, it means there's some stenosis proximally, that's where there's flow diversion. So collateral is pathological and accessory is A grade vein, it's not abnormal. Okay, so that we have to, and if the part is, if you ligate a collateral vein, the consequence would be catastrophic. The fistula may get thrombosed completely. Okay, so you have to ensure that it's not, when you are ligating, it's accessory vein, not a collateral. Well, it helps in detecting the stenosis. So if it's in the juxtaanasmotic segment, there you get a peak systolic velocity ratio of more than 3, and it will be correlating with the stenosis of the anastomosis there. And of course, it helps in prediction of, overall, it helps in prediction of maturation or immaturation. And finally, especially in a country like us, where finance is a big issue and the nephrologists do not have very ready access to the cath lab, if you are trained enough, because this is the peripheral lesion, basically non-maturity is a peripheral lesion, so one can go ahead and perform UST guided angioplasty, and that's nothing better than that. Well, contrast angiography, this is only when I have to take the patient for angioplasty, then only I'll do the contrast, and not to make a diagnosis of stenosis. It will be clinical or based on Doppler study. A bit of concern is if the patient is pre-ESRD, then there might be some sort of worsening of the kidney function and the patient might land in dialysis requirement. Just for the academic purpose, contrast enhanced MR angiography may also be done. It's a non-ionic, lacks this non-invasive, lacks ionizing radiation, and it can map the entire vascular tree, and it has high accuracy for stenosis detection. But the problem is high imaging cost, then nephrogenic systemic sclerosis, and absence of MR-guided access intervention. So we are not performing any intervention based with MRI as the imaging modality. So it will be merely for detection. So briefly, coming to the indication and timing for intervention, KDOQI doesn't recommend any routine endovascular surgical intervention, and decision has to be made on case-to-case basis. Usual indications are, this is something the PGs can remember: small vein diameter, significant stenosis in the outflow tract, presence of stealing branches, and inadequate volume of flow. Timing, there's no consensus again when one should intervene. Usual time is about 6 to 8 weeks of time. Usually I will not intervene before 4 weeks, because this is a time when if you try to intervene, there may be gaping of the fistula also. The wound might gape and there might be catastrophe over there. So before 4 weeks, I'll never intervene. Maybe I can wait up to 6 weeks if I feel like it's okay. But prompt treatment is required when you identify there's some collateral or accessory vein, or there's some significant hemodynamic stenosis, then you might intervene even earlier. Well, what are the options to assess the AVF maturation? Non-invasive techniques, there are a lot of published publications which say something about, but they have got inconsistent benefit. Exercise, of course, is the one which is harmless, and KDOQI recommends entire limb exercise rather than finger exercise. Intermittent compression, topical application of nitric oxide or infrared therapy, these are locally delivered, and the results are, I would say, it's not harmful at all. The results are doubtful. Clopidogrel, it prevents early thrombosis but no effect on maturation. Clopidogrel and iloprost, this was published in IJN. This has got significant lower maturation failure. Now coming to the invasive techniques, they are plain old balloon angioplasty when you identify an stenotic lesion, and other is balloon assisted maturation. I'll be coming to these things in later slides. Coming to the plain old balloon angioplasty. So here what do? You simply pass a balloon across the stenotic segment, inflate it, and you get it. So you can see over here, this one has got stenosis in the juxtaanastomostic segment, plus in the inflow artery, or this is site of possibly the bulldog that we have applied for clamping the vessel, that is the place. So I had to perform angioplasty of both the segment, that is juxtaanastomostic segment and the proximal radial artery also. So then you have got a very good result afterwards. Now this is another patient where the patient had fistula constructed in the month of August, and I had done it maybe about 2 weeks back. So he had come for non-maturation. So you can see the angiogram again. You can't see any dye coming to the venous part because this patient had got stenosis in both, anastomosis also. From the balloon you can make out that there is stenosis in the body of the fistula also. Again you can see there is stenosis in the juxtaanastomostic. This is a very common thing to happen, common in clinical practice. The mid one, this could be because of some prior venotomy, some haven't done the phlebotomy, and the result is this one. So one thing is, if you want a good vascular access, you'll have to educate your nursing staff, your phlebotomists, not to touch the cephalic on either arm. Okay, so this goes a long way. I mean, I have seen several patients, they have no vein at all because the patient had got admitted and thereafter puncture had been done. So this is the one which I had done angioplasty. I have not shown the angioplasty of the anastomosis. I required 5 mm balloon there also. And it was resistant one. It required 25 atmospheric pressure to dilate that one. And the final result is this one. This is, gratifying for anyone. So balloon assisted maturation, basically, here you don't have any stenosis per se. So the vessels are small and you try to do control injury to those vessels so that the vessel dilates. This was the patient about 2.5 to 3 years back. He had right-sided central vein, complete occlusion, could not pass through. He had thrombosis of this brachiocephalic fistula, and he had come to me for this fistula construction. So he was a government employee. So I'll tell you why this is important. So I constructed a transposed radiobasilic fistula. Okay, so after 3 to 4 weeks of time, you can see the size of the vein is so small that with a Campi catheter of 5 French, whose external diameter would have somewhere around less than 2 mm. So without any compression, I can do the reflux angiogram. So it's occluding completely. So initially I performed angioplasty with 4 mm balloon, then went up to the 6 mm. You can see the result of the 6 mm balloon. And finally, I took him up with the 8 mm conquest balloon. So the result was this one. And this man had come to me about a week back. I mean, in between he has been requiring angioplasties. So every 4 to 5 months, once he will come, meet a partial occlusion or stenosis. Now the technicians can't cannulate the fistula and then add to the angioplasty. So this man has come about 5 months now, after 5 months of last angioplasty, doing completely well. And this is very much gratifying that this fistula is working. The big point was, this patient is a government employee and he is being paid for all the intervention by the government. Otherwise, I'll come to the results. So you see, the clinical success may vary from 43 to 97%, and 1 year primary patency, that's without any intervention after index intervention, varies from 34 to 72%. This is the common with all the angioplasty that you do in the peripheral venous system. But the 1 year patency, assisted patency, that is second angioplasty you do and you get something 68 to 96%. The implication is the procedure per se, the technique per se is okay, but the patient must be having a big bag full of money because they can't afford the angioplasty so frequently. Doing something like this, you perform an angioplasty will cost somewhere around 30 to 35,000 at the bare minimum. Okay, and you perform every 4 to 5 months, the patient will not afford to it. Although I'm in Uttarakhand and I'm lucky that there the health is completely provided to all the domiciles Uttarakhand under Ayushman scheme. So even if the patient is coming BMW car, he is eligible for that one. So in a way, I'm a big beneficiary to Ayushman that I can do all the interventions in that program only. So that's why I am doing that. So the point is, balloon assisted maturation it has got the prawns that it expands the AVF pool, that even if the patient is having very small caliber vessels, you can take up those patients for fistula construction. So it reduces the TDC duration, and once you do it, you get larger and thick walled veins, which is easy to cannulate and resistant to cannulation injury. The cons, as I said it requires repeated angioplasty. I mean, what is us saying that angioplasty begets angioplasties. That one angioplasty is not the last, but it's beginning of the angioplasties to follow. So they must be having bag full of money. They can't afford it. So surgical option for maturation are proximal neoanasthesia. As I said, the most common lesion is juxtaanasmotic segment. So considering Indian scenario, where the finance is a huge issue, so what you can, at the most you will have to sacrifice say about 1 or 2 centimeters of vein, you can construct a new fistula proximally. It works equally well. The 1 year patency rate is the same when you do the PTA or this one, but that will be far cheaper. And in fact, the patient gives this excuse also that if it costs so much, I can get a fistula constructed in far lesser money. Ablation of the accessory one, this is a simple one. This can be done by the endovascular coiling, but then it becomes expensive. Or the simple one is under local anesthesia, you can do it within 15 minutes. It's over. It doesn't require a lot of skills. Simply you need to have hemostasis and then you can do it. Superficialization of brachiocephalic fistula and brachiobasilic. Many a times we come across where the brachiobasilic fistula has not been transposed. So they will simply connect the basilic vein with the artery. And the basilic vein has this much is the superficial one. Okay, afterward it pierces the deep fascia. So beyond the deep fascia, if the patient is not completely skinny one, you won't be able to cannulate properly. So there's problem. So the treatment is you just superficialize it or you the transposition also. So you bring it not only superficialize but bring it in front. So this is superficialization plus transposition. That is far better. And rarely do we come across a situation where in the forearm also the patient is so obese, there's so much of fat that even you require superficialization of cephalic in the forearm, but this is very uncommon. You can require superficialization of brachiocephalic fistula sometimes. Well, this has to be individualized, whether one should go for a new AVF construction or one should go for endovascular intervention. I gave you the pros and cons of both the sides. So the decision has to be taken with consent of the patient, because as I said, one angioplasty will lead to another angioplasty, so it's a repetitive cost wise. So you have to take those considerations. So my algorithm is If a fistula has been constructed, they should see the vascular access surgeon or center at 4 to 6 weeks of time. Assess for maturation. If it has matured, add the surveillance, or if you want to use it, you can use it. If it has not matured, the possible reason could be either there's thrombosis, so you have no choice but to construct a new fistula in these cases. Or if the depth is more than 6 millimeter, then the choice is surgical superficialization or transposition. However, if the depth is, diameter is less than 4 millimeter and blood flow is less than 500 mils per minute, then you have to see for stenosis. You can perform diagnostic angiography. In that, if you get arterial stenosis, do the PTA. If you get venous segment, that is beyond the juxtaanastomodic segment stenosis, again you do the PTA. Or if there is juxtaanotic segment, you have two options. Either you can go for neoproximal anastomosis, or you can go for angioplasty. And if the fistula matures, you can continue using, and you'll have to continue monitoring the surveillance of this fistula. Whatever I have talked so far, it's already when the events have happened. That is, after construction of the fistula, when it has started. So, are there means by which we can prevent this altogether? Well, there are pharmacological mechanism, drugs there. They are in the process of investigation. They are rapamycin, cyclosporin, sirolimus, but all these are in preclinical stages. So I won't be going in any detail of them. Surgical, few of the descriptions are radial artery deviation and reimplantation. Again, here usually what do? We take the cephalic vein and move it towards the artery, that is mobilize the cephalic vein and anastomose in the artery. So this is, because of this torque, there will be stenosis of this one. So other way of thinking is, why not to mobilize the artery itself? Okay, but you have to be very careful that the circulation should be good enough to sustain this one. Otherwise, the patient can develop ischemic symptoms. So the studies are there which supports this one, but again, this is investigational, not commonly accepted so far. Other one is modified node touch technique. So when we construct the radiocephalic fistula, what do? We completely skeletonize both the artery and the veins. Here, what happens? You are taking both the artery and the veins with some amount of tissues over there, so that you are not injuring the vasa vasorum per se. So studies are supporting that this might reduce the chances of stenosis in the vessels. Finally, this one, I discussed about this one, piggyback straight line onlay technique. So this is promising one, and I practice this one only. Well, this is an Israeli company which has brought this one. This is a nitinol-based external support. So this maintains the configuration of the artery and the vein. So this is done intra-op, and again, this has shown some promising result still to come into the open market so far. So take-home message is, first and foremost, preserve the artery and vein in all the CKD patients, whatever stage he or she comes to you. Not only you have to do it, but you have to educate your nursing staff, your phlebotomist, and the patient himself or herself. That if the patient doesn't know, very difficult that they will follow it. Whenever required, pre-op vascular mapping should be done. And most importantly, the technique has to be proper. The teaching and the training of the person who is constructing the fistula should be good one. Evaluate the fistula for maturation at 4 to 6 weeks of time, and consider pros and cons of construction of new fistula vis-a-vis salvage of the fistula by endovascular technique, and timely endovascular or surgical intervention required, as and when required. Thank you so much.
Thank you, sir, for this wonderful talk. I think I'll pass on mic to Rajapukka sir and Logo sir to make some comments on that.
Well, I think very, very well spoken, and I've seen your work, which is very good. Having said that, I would say that a person who does it, whether you are doing intervention or surgery, one is that the person should be interested and he must have a stake in the outcome. Then whether he is a nephrologist constructing, surgeon constructing, vascular surgeon constructing, if the person is not interested and the outcome he has no stake in, I just can hear the surgeon telling you, but I can hear a bruit. Cannulate karke dikha bhai. He never comes to dialysis unit to see. So therefore, if you are the person who is going to do the dialysis yourself, then you will construct it better. You will learn the surgical technique. When I used to do it, I used to open out subcutaneous tissue around the vein so that the vein dipping would go away. That is, so in my hands, when I used to once upon a time do, I had much less failure than my surgeons.
Yeah, I mean, the most important part is how much the person who is operating is interested in doing it.
Yes.
So, I mean, this is a closed house. I hope nobody brings things outside. There was one surgeon, and he did not have an interest in constructing it. So, I brought the video for brachiobasilic. So, lastly, he exclaimed and told me, I'm not interested. How can you expect the fistula to be good in those hands? So, if they don't have any stake into it, the fistula are going to fail.
Ultimately, they don't have to look after that patient. They're not answerable to the patient. They're not answerable to the nephrologist. They're not answerable to themselves. They've already taken their operating fees and gone home.
And very often when you send patients back to them, they'll write a single sentence, fistula is working well. And after they return back to you, what do you do?
So I once did what Dr. Rajapur, I said, please come to the dialysis unit and cannulate it and show me.
They're too busy, sir.
Great job. Two questions. Are you doing ultrasound guided angioplasties?
Yes, sir.
And the second is, what is your opinion on drug coated balloons?
I'd say my limitations are, I work in Dehradun, that is covered entirely by Ayushman, so they have limitations. Regarding ultrasound guided angioplasty and thrombolysis, well, I have been compelled by the circumstances to go for these things, so I started doing, otherwise I was not trained in doing USC guided. Because when we ask for angioplasty, that is conventional angioplasty, the cost prior to that will be 5,900 in my institute. That is, they have to get an echo done, they have to get a Doppler done, and prior to that they have to get angiography done. So it will cost 5,900. So in my unit, if I go, I charge for 3,000. I'll be reusing my old balloon. So that way, it saves the money. As regards to thrombolysis, the situation is the same. There's no code for thrombolysis in Ayushman in Uttarakhand so far. So what do you do? Your patient is in front of you. What do you do? I have to go ahead. So I'll charge them 4,000. Okay, I'll have retiplace and I'll install it and do the angioplasty and thrombolysis. So it succeeds. As regards to drug-coated balloon, well, during my training I had used it at Singapore. And in fact, my mentor, Dr. Tanchi Soy, he had been part of this magic touch, that sirolimus-based drug-coated balloon. But back in my place, the cost is big factor, so I can't do it.
Well,
But regarding experience, it's not something magic thing कि एक बार हो जाएगा तो fistula हमारा हो जाएगा, ऐसा नहीं होने वाला. So this simply buys the time for the intervention. So if you have used DCB, maybe the fistula which will recur in 4 months of time, maybe it goes for 6 or 7 months. But it will definitely recur. So basically angioplasty is something solution to, we are trying to give a solution of biological problem and giving a mechanical solution. So it's not going to work. So we have to have biological solution to the same problem.
Well, as far as thrombolysis is concerned, that's a good thing, but if the thrombolysis or thrombosuction, whatever you do to remove the thrombus, and if it is not followed by proximal angioplasty, it's sure to fail.
Yes, sir.
So that has to be simultaneously done.
In fact, the coding that we were using during my training was thrombolysis and angioplasty.
That is always required.
That's always the case. Rarely, very rarely, when the BP of the patient is around 110, maybe you don't have stenosis and the BP has gone down, so you just massage it. So by that way, 1 to 2 patients every month I do it, so they will recover. But it's not the rule. The rule is it's thrombolysis and angioplasty.
About the drug-coated balloons in peripheral circulation, I have personal experience as a patient. They're useless.
Another problem is drug-coated balloons. You have to always use a first balloon, normal balloon, and then use a drug-coated, and you can't reuse. And we are allowed to reuse. So that's the problem when drug-coated balloon you have to use, because you are anyway using one balloon prior to the plasty, and then again choose a correct drug-coated balloon. So it becomes 2 balloon for even procedure.
Now, Government of Maharashtra doesn't officially allow any reuse.
Has got rated burst pressure not more than 14. So it's very poor. In peripheral, in vascular system, when we use the balloons will require pressure somewhere around at the least 16, 18. So this is way beyond this one. So you'll always need a second balloon. So then cost goes up. In fact, during my training, myself and my mentor got an explanation from Singapore Medical Council that you have used 3 drug-coated balloons, so it costs so much. Patient had complained to the council.
Okay. Thank you, Shahbaj sir, for the
Thank you so
talk.
much.